recapitulation of the lumbar spine anatomy. We have 5 lumbar vertebrae, which are starting from the lumbar 1, lumbar 2, lumbar 3, lumbar 4, and lumbar 5. Now, if we see any vertebral body, it has the following components. For example, it has a vertebral body. So you can see anteriorly, this kidney-shaped portion is the vertebral body. From the vertebral body, they are stacked one over the another with the help of the intravertebral discs. Now, from the vertebral body, there are 2 pedicles that are going to the posterior side. So this is one pedicle, this is another pedicle. And they are joining with the middle and posterior elements of the vertebral body. So what is there in the middle element of a vertebra? So first of all, we should understand the area of the pars intra-articularis. This is the bony area, or it is called the pars intra-articularis. Remember, there are a lot of structures which are connected with the parts. So from the anterior side, it's the pedicle. From the lateral side, it is the transverse process. From the medial side, it's the lamina. From the superior side, it is the superior articular process. And from the inferior side is the inferior articular process. So that is how a lumbar spine is formed. Now we have a lumbar canal at the lumbar area. We all know there is no spinal cord, only the nerve roots and the thecal space, thecal sac is there. So through this area, remember at the L1, the spinal cord ends and the thecal area with the nerve roots, it comes through this area. And there are 2 foramens. This is the vertebral foramen, and in this we have the intravertebral foramen. How the intravertebral foramen is formed? When we are getting the whole spine, we can see these areas of the intravertebral foramens. Here we are having the discs in between these vertebral bodies. This blue colored portion are the discs, and there are ligaments surrounding. So what are those ligaments? From the anterior side of the vertebral body, we are having the anterior longitudinal ligament. Similarly, from the posterior side of the vertebral body, we have the posterior longitudinal ligaments, and further posteriorly, we are having the ligamentum flavum, which is connecting between the 2 laminas. Then we have the intraspinous ligament and the supraspinous ligament. And there are lateral intertransverse ligaments as well as there is a component which is going from the medial side. Now, these inferior articular facets are joining with the superior articular facet of the lower vertebral body, and they are forming these zygopophyseal joints, or in simpler words, they are called the facet joints. Okay, these are small synovial joints at the back, and like all synovial joints, this might go in arthritis as well. Now, this is the foramen through which the nerve roots come, and through which also the segmental radicular arteries, they go in and they are forming the spinal arteries. And here we are having this foramen. This is very important because either it can be occluded by a bulging disc or it can be occluded by a hypertrophic facet causing compression over this root. But moreover, when there is inflammation at this area, that can't compress over the nerve root. So we'll be talking on most of these areas. So this is just a small recapitulation. Now, back pain is a very well-known global problem. To be frank, its prevalence is around 60 to 70%, and it is the leading cause of disability. And you will be finding the surprising thing. The most bad part is that it is affecting more of the age group, which is primarily the economically productive group, that is 30 to 50 years. And obviously, it is having a huge economic impact. When we back to India, the prevalence in the low back pain is in the range of the global range, that is 50 to 80%. And at any given time, 23.9% of them are suffering from. But in India, there are some other differences like an occupational factors. Okay, either the laborers in the rural areas and the sedentary job workers in the urban area, they are the major contributors for the occupational factor. And another problem for the rural areas is that the healthcare access is limited. So the patients have to suffer for long. But it's a very good thing that 90% of those cases they resolve spontaneously within 4 weeks, regardless of any treatment or without any treatment. So you might ask, sir, you have done a very good job. You have told me that you do not require a treatment. Whatever happens in a 4 week time, it might resolve, 90% will resolve. But should we wait then for all patients to wait for 4 weeks? The answer is both yes and no. Why? Because in some patients, you give some conservative management in the form of an NSAIDs, in the form of a paracetamol, and then you can wait to get it resolved by itself. That's good. But the patients are having, welcome Ananda, and congratulations for being the topper in the last evaluation. So Ananda just joined. Anyway, so what we are talking about is that should we wait? The answer is we can wait. But in such a situation where there is no red flag signs. What are the red flags? In low back pain, there are certain situations or conditions when the waiting could cause a more disability for the patient. So in those areas, we should not wait. We have to go for the prompt management. But in the rest of the cases, we can wait with the conservative management. So let's see what are the red flags in a low back pain. First of all, if the back pain is associated with a major trauma, we should immediately go for an evaluation irrespective of the condition, whether the patient is having pain or not. Okay. Then if we are suspecting there could be a possible tumor or we are suspecting there could be possible infection. How can we suspect? We can suspect with the recent change in the body weight, recent change in the history of presence of fever, recent change of neck pain and nature, mainly nature and intensity. So if we are suspecting those conditions, then definitely we could not wait. So that's also a red flag. Then suspected fracture, and there are progressive neurological deficits. So neurological deficits may be of autonomic, motor or sensory, but remember motor and autonomic neurodeficits are most important. For example, if the patient is losing the bowel control, so it is a red flag and we have to go for a urgent surgery. If there is progressive weakness of the lower limbs, we could not wait. So we have to go for the treatment immediately. And severe pain, some people say it is also a red flag, but it is not always. Remember, sometimes pain is a subjective thing. So some patients, they might feel the pain very severe, even though there are no red flags present. So you should be careful in judging a patient with the red flags. If there are red flags, immediately start the evaluation and then definitely the investigations, and you should immediately start the management. Because if these patients are left untreated or if these patients are put in a conservative management, then there is a possibility the outcome may be worse that we do not want. Now coming to the challenges for the rest of the patients. As I told, patients with the red flags, which are actually less than 1%, we are going for the immediate further management in the form of invasive surgery or in the form of antibiotic therapy or whatever because of the disease condition, depending on the disease condition. Now, 90% I have already told they are recovering spontaneously. But these remaining 9 to 10% patients, they becomes a challenge for the management in the modern medicine. Among those patients, it has been found that for 10 to 40% patients, they are treated by the alternative therapeutic modalities like a physiotherapy, like a chiropractor. So they can resolve. But remaining 5 to 6% is a real challenge. And majority of these sufferers had no identifiable pathological cause with conventional investigations, including CT and MRI. So these patients, what happens? They goes to a neurosurgeon, then an orthopedic surgeon, then a pain physician, and so on. So remember, pain is not only treated by the pain physicians, but also persons from the other specialties, they also contribute. For example, rheumatologists, they're also contributing to this management of pain. So pain is always multidisciplinary term. And one thing is remember, these patients should not go on searching for doctors, but it's the reality and the sad reality, and we have to stop this. So as much as 90% of these 5 to 6% patients, the source and pathologic mechanism is not known with the conventional investigation processes. And sometimes it has been found there is a poor correlation between the pathology and the clinical findings of the spinal pain. For example, you get an MRI done of a 60 years of old patient, and you will find there are a lot of degenerations, lot of disc looking back. Sometimes there might be disc bulges, but they not all are contributing to the pain. Similarly, in an asymptomatic patient, around 28% of the patients you might find out some pathology in the spine of an MRI. So there is always a poor correlation between an MRI picture or CT scan picture and the actual symptoms of the patient. There are other factors definitely involved like psychological factors, central pain factors. They makes this poor correlation. So what should we do for those patients? Are everyone able to realize the problem? More complicating to this problem, what happens? Sometimes there are secondary depressions, but studies by Wildman has shown even in those patients, nociceptive pain sources can be regularly identified with the help of the interventional pain procedures targeted at the spine. And when we reverse these nociceptive pain sources, or in simple words, pain generators from the spine, then definitely we can go for the successful treatment. And after successful treatment, this psychological profile comes back to normal. Now coming to the another very important thing, structures responsible for low back pain. So let us see what are the structures contributing to a back pain. So coming to a commoner things, first of all, disc. Disc can be a source of the pain in two ways. Number one, when the disc is damaged within, that means inside the disc, some changes occurred and the discs become pain sensitive. This condition is known as the internal disc disruption, or in simple words, we can call it a discogenic back pain. So there is the problem within the disc. The next problem the disc might cause is that the disc is bulged, they are coming out, they are causing inflammation at the nerve root or doing compression to the nerve root. So what will happen? The patient will be having a radicular pain in a dermatomal distribution that is supplied by that nerve. This is known as the pain because of the herniated disc or a lumbar radicular pain. Sometimes the term lumbar radiculopathy is also used interchangeably, but though those terms are used commonly interchangeably, the meaning is slightly different. In radicular pain, it is the only pain. In radiculopathy, it means pain either reflex or motor weakness or sensory damage is there. Sensor is not that important, but I always say it is the motor weakness and the reflex action. They are more important, but they are damage that is usually called a radiculopathy. Next, coming to the second pain generator. So we understood one pain generator, that is the disc. The next is the facet joint. So the facet joints, as I showed you, that found in the just posterior part of it. And these joints are like all other joints, they can undergo degeneration. and this becomes painful. When this joints becomes painful, then the patient usually complains of pain in the low back, and as the joint is situated in a posterior part of the spine. So whenever the patient is bending posterior, there will be increase in pain. Can anyone tell in discogenic pain which posture will increase the pain?
The forward bending.
Yes. What happens? Disc is anterior. So when the patient is bending forward, there will be more pressure and that will cause more pain. So we have to understand this mechanics so that we can actually detect those patients. Now, there are some situations when apart from the disc and the facet, the other components of the spine could be painful. For example, vertebral compression fracture may be traumatic, maybe osteoporotic, or maybe a malignant fracture. So that could be a cause of pain, and we all know the compression fracture patients, they have problem in sitting because whenever the patient is sitting, more loading occurs over the vertebral body and the disc. So the patient complains, and usually the patient pain is relieved slightly on lying down position. Now coming to the spondylolisthesis. What is spondylolisthesis? When one vertebral body is anteriorly or posteriorly shifted from its position with respect to the lower one, we should call that anterolisthesis or posterolisthesis. And with the anterolisthesis and posterolisthesis, the things might happen. There could be increased loading of the facet, leading to a facet joint pain, or sometimes there could be a compromise at the root, causing a radicular pain. At the early stages, the discogenic pain might be there. And it is also graded according to the percentage that how much one vertebra is shifted from the other, mainly the lower one. Up to 25%, it is said grade 1, and similarly up to the grade 4 with a complete displacement over one another. So these are in short the causes that is coming from the lumbar spine. But remember, only the bones and the discs are not the only structures. There are muscles and other structures too in the lumbar spine. So what are those structures? Here we have the sacroiliac joints. And they are also very close to the lumbar vertebra. So whenever there is inflammation in the sacroiliac joint, the patient feels pain in the low back. So sacroiliac joint arthropathy, which is similar to a facet arthropathy, that can cause back pain. Now, why a sacroiliac joint can be painful? Because either of the degeneration, which could be age related or which could be because of the unequal distribution of weight. For example, a patient have injury in one leg, there is limb length shortening, then there is unequal loading over the sacroiliac joints, and the joint which is having the more load, they will undergo arthritis earlier, and that can cause pain. Similarly, there are certain situations where the sacroiliac and facet joints they can undergo inflammation. For example, a spondyloarthropathy patient, because of the inflammatory disorder, they are becoming painful. Now, there is another term which is previously known as the piriformis syndrome, now called the deep gluteal syndrome, that could be a cause of the pain. So piriformis is one muscle that is originating from the anterior part of the sacrum of the S234 and going to attach with the greater trochanter. And just below this piriformis muscle, there is a nerve that is known as the sciatic nerve. So whenever there is spasm in this piriformis muscle, there is a disease which is known as the myofascial pain syndrome. As I have not told that disease earlier to you, so I'm not referring to it, but it is actually myofascial pain syndrome. So here, because of the spasm, there will be pain over this nerve, and the patient will be having pain along this nerve. Just 1 second. So now Here what you can see that could be cause of pain, that is the sacroiliac joint pain, and as well as some cases of hip joint. Though hip joint can be easily distinguishable from the low back pain, but though sometimes it may be confusing as well. And this condition, which is piriformis syndrome, and or nowadays it is called the deep gluteal syndrome, because it is believed that not only the piriformis muscle but the other muscles like quadratus femoris, gemellus, and ocular internals, they are also involved in this process. So now it is called the muscles just under the gluteus maximus, so deep gluteal syndrome causing acute-sciatica type symptoms. Then comes to the other muscles like the psoas major, like quadratus lumborum. If they undergo spasm and there is development of the myofascial pain syndrome, definitely myofascial pain syndrome is very important. We'll discuss in the next classes. So that can cause also pain. And this is another cause of back pain. So in short, if we go back, then we can say the common causes of back pain are the disc disorders, facet arthropathies, sacroiliac arthropathies, spinal stenosis, vertebral compression fracture, disc herniation, disorders related to the muscle like piriformis, quadratus lumborum, psoas, they can all cause the back. Now, based on the knowledge of the pain generators, some diagnostic interventional procedures has been invented. And these are the tools that the pain physicians mostly use. So what is a diagnostic pain procedure? In very simple words, you can understand. I am suspecting a pain originating from a facet joint. Okay, say a left L45 facet joint. If we inject a very small volume of the local anesthetic, for example, 0.4 ml of local anesthetic within the facet joint, and ask the patient that whether your pain is relieved or not. Now, though there are no changes found in the MRI or CT scan, if the patient says that after this injection my pain is relieved, what will be your conclusion? Can anyone
The
tell?
pain is the pain is around the
Yes,
facet joint.
pain is originating from the facet joint.
Hmm.
Similarly, if one nerve root, I am suspecting this root might be inflamed and pain is originating from this root. If you inject small volume of local anesthetic and then gets relieved, then it is also signifying that root was painful. So we have invented so many procedures in the pain management that can help to find out those conditions. So diagnostic facet joint block for the facet pain, provocative discography for the internal disc disruption or discogenic low back pain, epidurogram for the epidural adhesions or any other pathology in the epidural space, spinal endoscopy. Again, it is mostly the fiber optic endoscopy to find out for the diagnostic part. Then selective nerve root block, as I just given the example of the nerve root that is done by selective nerve root block. Similarly, SI joint block, and nowadays it is called the SI joint intervention. So initial diagnostic intervention is basically injecting small amount of local anesthetic and sometimes steroid to give some therapeutic benefit. So that could be a possible cause. Then sympathetic nerves. Remember, apart from the somatic nerves, we have the sympathetic nerves. They are important for the maintaining and initiating a type of pain which is known as the sympathetically mediated pain. One of the example of such pain is the complex regional pain syndrome. So in those cases, if doing a sympathetic block or in some conditions, if there is a vasospasm, in those cases also, we are putting a sympathetic block, and sympathetic block causes vasodilation, and if the pain is relieved, that is also a conclusion that this pain is originating from that structure. And differential spinal or epidural block. So these are all ways of diagnostic IPM procedures. Okay. Now, on those 50 to 60%, 5 to 6% patients, when these diagnostic interventional procedures were performed to find out the cause of pain, it has been found that facet joint pains account for 40% of those 5 to 6% patients. Discogenic pain contributes to around 26% patients of this facet joint pain. Sacroiliac joint pain around 2%. Segmental nerve root pain is usually around 19%, and no cause identifiable even in 19%. So remember, 80% of those patients who are in a diagnostic dilemma, moving to doctors, now they are 80% cases we are able to diagnose and find out the pain generator with the help of diagnostic interventional pain procedures. But remember, these numbers vary a little according to study to study. This is a specific study which is done in 2001 by Lakshmikant Manchikanti, and these were the results. So, based on the different studies of Manchikanti and the other physicians, we have classified these common causes of back pain. So, we have taken most of the average from different studies to find out which are the common causes. It has been found that facet joint arthropathy, which is the commonest cause in the older group of patients, constitutes around 15 to 45%. The number is a wide range because of the studies obtained from different studies. Internal disc disruption, which is the commonest cause of low back pain in a younger patient, that is around 25 to 40%. Sacroiliac joint arthropathy, which is constituting around 15 to 30% cases. Disc prolapse, herniated disc or slip disc, they account for 2 to 5% cases. CRPS or the reflex sympathetic dystrophy. Basically, previous name was the CRPS type 1, that is that reflex sympathetic dystrophy that constitutes around 2 to 8% of the patients. Now, coming to the other causes, like osteoporotic compression fracture, around 3 to 5% cases, other fracture less than 1% cases, fibromyalgia and the myofascial pain around 2 to 5% patients, spinal canal stenosis around 2 to 3% patients, spondylolisthesis 2 to 3% patients, tumors less than 1% of the patient, less than new infection less than 1% patient, and others like feedback, they are also less than 1%. Now, you might ask what is FBSS? The full form is failed back surgery syndrome. A newer name is post-laminectomy syndrome. So, if the patients after the spinal surgery, they are having the pain in the back, they are known as the failed back surgery syndrome or the post-spinal laminectomy syndrome. So, it's a altogether different chapter we will be discussing in advanced section of this course. So, they are also a big challenge for the management for the pain physicians. Now, coming to the one by one diseases. So before I go into the diseases, if you have any questions regarding this diagnostic interventional procedures concept, we have to make this concept clear. And on this concept, practically we are doing a lot of interventional procedures. So any question? I always ask you questions. I welcome questions because then your concept will be clear. And if this concept is not clear throughout your pain management journey and career, you will be having difficulty. Once this concept is clear, everything will be smooth. Dr. Satish, you have actually opened the microphone. So
Yes,
any
sir.
question? Yes.
Excuse me, sir. So in red flags, you said that severe pain is also a red flag. So I could not understand how severe pain is there.
I have given a plus minus. Okay. Some says if the back pain is severe, that could be a possibility of a dangerous disease. But this is not always true. That's why I have given 3 question marks there. Because severe pain doesn't always mean it is a red flag sign. Okay. But if the pain is severe and then it is not responding with the conventional management, then you have to do the investigations. That is the only purpose of writing it.
Sir, you just mentioned about the diagnostic modalities. So how do we like decide which patient, just based upon history, that which patient we have to do diagnostic interventions to confirm the pain, or based upon any scans, imaging altogether?
Usually we put in the first step is the history. Then is our physical examination. These 2 parts we'll be discussing today. After that, it is the third part, that is the investigations. Then we have to go for the interventions. Okay. Then final management. Okay. So it comes in the 4th step, not in the first step.
Okay, sure. Thanks.
Okay. Let's move on. So first, I'll be talking a little bit disease-wise, the most common disease I'll be covering. Then I will go according to the symptoms, how we will, from the patient, will be diagnosing clinically. So facet joints, they are paired joints at the posterior part of the spine, and usually they are formed by the inferior articular process of the upper spine and the superior articular process of the lower spine. They are the small synovial joints remaining by the side of the midline, and they can go arthritis and can cause back pain. This is a very important slide that when the facet joints are painful, usually the patient complains that my back pain is more compared to the leg pain, because most of the patients comes with a more of a back pain, less of a leg pain. Okay, and some patients come with the there is leg pain is more or editing component is more, back pain is less. But in facet joint pain, back pain will be more than leg pain. Next, as the position of the facet joints is by the side of the midline, then pain on the side of the midline. Remember, sometimes it can be confusing with the myofascial pain of the quadratus, because that is also by the side and the deep muscles of the back. So you have to differentiate from those, because if you are thinking of a myofascial pain, you can go for a trigger point injection and you can relieve for the muscular pains. But even then, it is the location just by the side of the lamina. So it should be 1 to 1.5 centimeters, and then usually after that the muscle starts. Okay, so muscles are there, definitely some muscles are there in the midline as well, but just by the side of midline the pain will be there. Then pain on extension, rotation and lateral bending. So whatever in the positions when there is more stress or pressure over those facet joints, the pain will be more. Patient extending back, the facet joint will be loading more, pain will be more. Patient rotating, okay, pain will be more. And with the movement, the pain will be more. Like an arthritic pain that increases with the movement. This is also an arthritis of those small joints. So here also pain will be increasing in movement. So how the patient usually complain? Patient complains that at night when I am changing sides, it is painful. When I am sitting to standing, okay, that means what happens? In our sitting posture, back is slightly leaned towards the forward side. From when we are sitting to standing, usually there is an extension. So with that extension, the pain increases. And on initial part of the walking, usually the pain is less. As we walk further, the pain increases. Okay. Usually there is no rest pain, pain related to the movement. There is tendinitis over the facet joints, and pain doesn't show dermatomal distribution pattern. Okay. So in which disorder the pain will show the dermatomal distribution pattern?
Radicular.
Radiculopathy, very simple. Now, what are the treatments? As I told, I'll be telling only the names. First of all, diagnostic injection for the facet joints. Then we can inject the intra-articular facet joint injection in the form of deposteroid, or we can do the diagnostic injection in a different way as well. In place of giving intra-articular injection, we can just inject to the nerve supply of the facet joints, and we can check whether the pain is released or not. That is known as the diagnostic medial branch block. Right? I'll be discussing when we'll be discussing the facet joint exclusively. And then if we are confirmed there is a facet joint pain, we can go for the radio frequency diazotomy. This is basically a procedure. With the heat, we are actually burning the nerves which are carrying pain from those facet joints. Okay, and it has of two types. One is conventional and one is pulsed. And nowadays the third type is also arrived, that is known as the cooled radio frequency. I think you have seen the radio frequency lecture. There I have discussed all three types of radio frequencies. Coming to the next part. Remember, the lectures which are given as a basic lecture, they are very theoretical topics, but we should at least twice see those lectures because there are a lot of information there. You will be able to know some demonstrations are also there. So, what is rhizotomy? In simple words, the nerves to the facet joints comes from two areas. The nerve coming above from this level, it is divided into two parts. One goes above, one goes below. So if for a facet joint, usually one nerve from below and the other nerve from above supplies. If we block in these two areas, diagnostic block, then it is known as the median branch diagnostic block. Now, if the median branch diagnostic block is giving the pain relief of this facet joint, we can go for hitting these small branches of the median branches and we can heal this pain or we can stop this pain from perceiving to the patient. And that is known as the facet joint median branch rhizotomy. Okay, so this is the rhizotomy of the medial branch. Don't worry, we'll come back. This is just an overview. We'll discuss all those disorders in a separate class. Okay, facet joint will be a separate class already. Now coming to the disc. As we know, disc has two components. This outer part, these are known as the annulus fibrosus, and this is the inner part, this is known as the nucleus pulposus. Nucleus pulposus is a jelly-like material where the annulus is made of collagen sheets and there are multiple sheets, usually 16 to 25 sheets of collagen lying in a crisscross fashion makes this annulus. So annulus is usually thick and damage usually do not occur very commonly because it can take the tension or the torsion from different areas because of this crisscross nature of this collagen fibers. So above and below line the end plates of the vertebra and below we have the nucleus pulposus at the center and we have the annulus fibrosus at the outer side. So we should remember in this annulus, usually outer third is having the blood supply and nerve supply. The inner two-thirds of this annulus do not have any blood supply or nerve supply, similar to the nucleus pulposus. So usually, even if some pain occurs here, it is not carried to the brain. So why God has made this type of arrangement? Because discs are made to take lot of pressure because they are the cushioning material for the spine. Whenever you are jumping, you are running, this is working as a cushion. Now, if there is a pain sensitive nerve there, and every time you are running, it is having the pain. So God has made in such a way that the inner part, whatever happens, I will not sense. Okay, you are made to withstand the pain, withstand the torsion. Okay, I have made you in such a strong fashion, and only the outer part is having those nerves. So this is the normal disc in the, this is the sagittal section, this is the coronal section. And you can see the nucleus is clear jelly-like material and you can see clear annulus. How they are formed? Usually the end plate, the cartilaginous part, it is having 55% of the water, 8% of the proteoglycan and 25% of the collagen. As we are going from this cartilaginous end plate to annulus, water content increases to 70%. Proteoglycan 5%, collagen 15%. As we come even inside the nucleus, water content is maximum 77%. Proteoglycan 14% and collagen 4%. So there is more water in the nucleus and comparatively less in the annulus, and in the end plate it is minimum. So whenever you will be looking at a T2-weighted image in MRI, so I have not told you about the T2-weighted image because we have the class later. So we'll be discussing definitely about those MRI readings. In the T2-weighted image, what is found is that the inner part of the discs, they look white. But what happens with the aging? With the aging process, usually this clean cut annulus and the nucleus all get dehydrated, and sometimes there are development of the cracks and fissures in these areas. Okay, so you see, when it is normal, it is looking like this in MRI. As the hydration level reduces, the water content gets reduced. So the image in the MRI also changes. These are all titulated image. As in titulated image, the water looks white. So when the disc is dehydrated, it doesn't always mean it's a degenerated disc. Dehydration is a part of aging, but whenever there are formation of the cracks and fissures inside this inner layers of the annulus. What happens? The nerves endings from the outer layer, they are also stimulated along with the vessels. So what happens? Whenever there are more pressure, formation of cracks and fissures, along with the pain sensitive free nerve endings, they enter to the inner side of this annulus. And now the problem starts. Now they start sensing pain whenever there is pressure or the interdiscal pressure increases, the patient starts feeling pain. So in those patients, what happens? Whenever the patient is bending forwards or the patient is jumping or the patient, if it is severe, then if the patient is standing, in the posture, whenever the body, upper part of the body pressure is acting on the disc, the pain increases. And this condition is known as the discogenic low back pain because of the internal disc disruption. Remember, the outer side of the annulus remaining intact. Only the inner part portion of the discs, they have become pain sensitive. That is why this is known as the internal disc disruption. So what will happen? The patient usually complains pain whenever there is increase in pressure. Though there is no compression over the nerve root, you have seen there is no impingement on the nerve roots. Pain distribution pattern is non-dermatomal. So where it will be dermatomal in radiculopathy, as it is compressing over the root, it should be dermatomal. But here it should be a non-dermatomal distribution of the back pain. And as these nerves, they are usually a part of the sympathetic system, the like a visceral pain. In visceral pain, you cannot localize it properly. Can you say that my stomach is paining or my liver is paining or my pancreas is paining? You cannot say. You feel a dull ache in the area where you are supplied or where there is pain. Similarly, this is also a poorly localizing pain. And incidence is comparatively high, approximately 40%. And straight leg rising test, this is a very common test which is done for the finding whether there is the radiculopathy or not. This SLR test will be negative. I will come to the SLR test, don't worry. And there will be no neurological deficits. No compression over the nerves, no neurological deficit. And in diagnosis, sometimes pain correlates with a diagnostic pain procedure that is known as the provocative discogram, or there could be possibility of a high intensity zone on MRI. Two terms I have told, one is the SLR and the high intensity zone. So SLR is a test for the radiculopathy. Whenever we are asking the patient to increase the angle of the leg, and it is around within 60 degree, the pain of the limb appears. It is known as the SLR positive, and it is usually found in radiculopathy. High intensity zone is an pearly white spots in the posterior part of the annulus. Okay, when it is seen, it could be suggestive of a discogenic low back pain. And there is a machine or procedure by which we can artificially increase the pressure of the disc, and you can check that whether the disc is painful or not. This is known as the discography and the disc monitoring, or in a simple term, it is known as the provocative discography. Provocative discography helps to find out whether the discogenic pain is there or not. Now coming to the treatment options. Remember, discogenic low back pain is still a challenge for the management for the even an intervention pain physicians. So there are multiple procedures invented. Among those, like the iDate, posterior annuloplasty, nucleoplasty, laser discectomy, conventional radiofrequency lesioning, no more recommended, but they are all tried. Pulse radiofrequency lesioning, percutaneous discectomy, ozonucleolysis, fusion surgery, disc replacement, stem cell injection in the degenerative disc, all have been tried. But nowadays, it is usually recommended that the simplest procedure, like a epidural steroid injection, that is usually preferred rather than the more invasive procedures, because we have to judge every procedure in terms of its safety. So as far as safety is concerned, we have to take care of such procedures which are comparatively more safe. Now coming to the prolapse disc. This is, I think, one of the most common pathology or well-known pathology, that when the disc is bulged or the disc material from inside has came into the nerve root, and they are causing and creating a small strong inflammation around the root. And when this inflammation occurs, there is pain. Okay. So remember, there is also a misconception here that the mostly it is the mechanical compression over the nerve that causes the pain. But that is not the reality, because in most of the patients, what happens, the tissues that has not come into contact with our bloodstream since the embryological period. For example, the lens of the eye. We all know when it comes out, it causes strong inflammation. Similarly, when the disc material comes out in the root, as they are not exposed to our immune system since birth, so they are also causing a strong inflammation here, and there is edema, and that compromises over the nerve space, and that causes the pressure over the nerve, and the pain appears. This is known as the disc prolapse or herniated disc. Remember, it is a continuum with the disc degeneration process, because in disc degeneration we have seen the cracks and fissures appearing. When these cracks and fissures appear in the outer third of the disc, and usually in those cases there is formation of bulges, and these bulges are commonly formed in the posterolateral area, as anteriorly it is usually covered by the anterior longitudinal ligament, posteriorly the posterior longitudinal ligament, but in the foraminal area usually there is no strong cover. Can it appear in the lateral side? Definitely it can appear, but most of the cases are neglected because it doesn't cause as much as pain as it happens in the foraminal area. So whenever it comes in the foraminal area, it causes an inflammation. Now the early stage, it is known as the prolapse. Then when the outer shell is out and the nucleus has come out, this is known as the extrusion. And when the nucleus portion isn't detached with the main portion, it is known as the sequestration. And with sequestration, it can either migrate inferiorly or superiorly, and we'll be calling it inferior migration and superior migration. So, how will be the pain? Here the pain will be dermatomal. That means it should go along the nerve root. So this dermatomal distribution we know from the beginning, so we are not going to repeat it. But two important thing is that L5 usually the pain comes in the great toe. S1 usually the pain comes in the little toe. L4 root usually responsible for the major reflex. There is no reflex for the L5 root, and L3 root slightly more medial. But most commonly involved root are the S1 and L5. When these are involved, they can impair the motor supply of the flexor and extensors, because L5 mostly supply the extensor muscles and
Debjyoti,
mostly supply the flexor muscles. Yes.
can you make the sound a bit more clearer?
Okay, I'm trying. So please, if you are having any issues, na, whether is it better now?
Yes. Sound intensity is not better, but quality. I
Quality
think
is better.
Yeah.
Intensity, same. Let me take it a little up. Now, is it better
Yes.
or the same?
Yes.
Okay. So now you can see S1 is causing pain in the posterior side. If it is involving the motor part, it is causing difficulty in plantar flexion. L5, whereas it is going more towards the anterior side, towards the great toe, and it, if there is motor weakness, it will stop the dorsal flexion or the extension of the foot. Now, can anyone tell in which nerve involvement L5 or S1 the patient will not be able to walk on the toes?
Sir, S1.
L5.
S1 now root. S1
L5.
now root pain.
Okay,
S1.
majority is in favor of the S1 and the answer is also S1. Why? Because extensor helps
Reflection.
to put the heel up. So when the extensors are impaired, then it is the S1 radiculopathy when the extensors are involved. Similarly, the heel walking, that means heel on the ground, toe up. This will be difficult if there is the L5 radiculopathy. So I think this part you have understood clearly. Let's move over. So in herniated disc, what will happen? There will be nerve root compression causing pain and neurological deficits. There should be dermatomal distribution of pain. Another, we are discussing a lot about the neuropathic and the nociceptive pain. So here what happens that the pain is primarily neuropathic pain because it is directly compressing over the nerve. Okay. So initially there is no nociceptive counterpart. The pain starts as a neuropathic pain. Here the pain pattern, leg pain will be more than the back pain. And incidence is around 4% of the population. And there is the pain in the lateral side and straight leg rising test will be positive. That means whenever we are putting the patient's leg up, then there will be pain and it should be within the 60 degree. If there is pain occurs more than 60 degree, you can neglect it. It is not specific to this disorder. But if the pain appears within 60 degree, it could be possibility that it is stretching the nerve root. Then neurological deficits like the weakness, numbness, or reflex syndrome might be possible. And diagnosis is the clinical exam or the MRI. Now, coming to the treatment options for the disc prolapse. So, epidural steroid injection, epidural nucleoplasty, then percutaneous discectomy, ozone nucleolysis, transfemoral ozone injection, discectomy, laminectomy, or fenestration surgery. These are usually recommended for the disc prolapse. Now, I have given you a long list. Not all the procedures are performed today. Some are historical, some are more commonly done. But the procedures like the epidural steroid injection is the first line, I should say. In most of the cases, it gives good result. And definitely, according to the severity, we have to go to other procedures. Sacroiliac joint arthropathy. So we have two sacroiliac joints by the side of the spine. When they are painful, they also cause the pain in the lower back. And you will be surprised, the L5S1 and the sacroiliac joint, they have similar nerve supplies. So what will happen? That is, if the pain is coming from the L5S1 or the SI joint, sometimes they are a little bit confusing because both cause similar type of back pain. Now, how the pain will happen in sacroiliac joint pain? So pain in the low back, buttock, hip, groin, often unilateral because bilateral sacroiliac joint involvement is comparatively rare. The pain may extend to the thigh, but rarely goes below the knee. Aggravating factor, pain worsens with sitting, standing, stairs climbing, and the transitioning positions. There is tenderness over the sacroiliac joint, reduced mobility like the stiffness in the lower back and the hip, and There are multiple tests for the sacroiliac joint pain, like the Faber test, Lindsley test, the compression distraction test for the trigger point. Treatment option, the simplest one is the corticosteroid injection. Then we can go for the conventional cooled radiofrequency or cryoablation. Definitely cryo gives a better result. Cooled also is having a comparatively higher result. And if nothing is responding, then you have to go for the fusion, mainly surgical for severe cases. Lumbar canal stenosis. So this is one condition that can occur either by a prolapse disc or by a hypertrophied facet or by spondylolisthesis. So whatever the mechanism is, well, ultimately they are compromising the canal diameter, and most commonly the central canal diameter. Sometimes the lateral canal stenosis might occur, but the symptoms will be different. When we say the lumbar canal stenosis, we usually consider the central canal stenosis. So what happens in those conditions? Remember, in these patients, the patients usually having a symptom that is known as the neurogenic claudication. That means when the patient, usually the aged patient, because it happens in an aged patient, the patient starts walking. After some time, the patient starts feeling numbness in the lower limb. Okay, there is pain, heaviness in the lower limb, and the patient at this position point gains some benefit when the patient is leaning forward, but even after some time he is not able to walk, and then he is resting, and after resting for a few minutes he can walk again. So this is known as the neurogenic claudication, and it is slightly different from the vascular or claudication what is seen in the Barger's disease, because here in the symptoms it is the mostly the neuropathic pains that starts. Now the explanation of that, the radicular arteries, because of this compromised diameter, when the requirement is more, they cannot supply the amount of blood that needs to deliver to that specific nerve. So though it is a neurogenic claudication, the primary mechanism here also remains a vascular claudication, but to a specific nerve that is supplying to that nerve. Okay. So what will happen in lumbar canal stenosis? There will be leg pain, weakness, numbness that will occurring during the walking. Pain is relieved by the sitting or leaning forward. Symptoms are usually bilateral. Standing or walking worsens the pain, while lying down or sitting improves it. Patient often lean on the objects or bend forward to reduce the discomfort. Now, after this, there is a chart. So, low back pain without radiation. If the pain is axial, you will think of a degenerative disc disease or a that is or a compression fracture. So, in degenerative disc disease, usually we will go for the procedures of the degenerative disease, and in compression fracture, usually we go for the vertebroplasty. If the pain is without radiation and paramedian pain, that is most probably it could be a facet pain or a SI pain or a myofascial pain coming from the muscles. So according to, we have to do our interventions. If the pain is with the radiation, with the global radiation, non-dermatomal, there could be possibility of a complex regional pain syndrome of the lower limb. And if there is a segmental or patch dermatomal pattern, there could be a disc prolapse. Okay. And if it is a non-dermatomal, there could be a facet SI involved. Okay. Remember, the radiation non-dermatomal might happen in pains of the facet SI or piriformis syndrome as well. Okay. So this is a short summary, but initially you have to know like this way each and every disease. Now when the patient comes, usually the picture becomes more complicated, because sometimes they are having multiple disorders together, or sometimes there is non-classic presentation of the disorders. So that will come with the practice and with experience.